Welcome to Digital Garden State, a podcast by the New Jersey Health Information Management Systems Society. Welcome to the New Jersey Health Information Management Systems Society podcast series, where we discuss emerging trends in healthcare technology and their impact on our industry. So I am your host today. I am Dr. Kennedy Ganti, one of the physician informaticists on the board of directors, as well as the current president of New Jersey HIMSS. And I have several of my colleagues on the board, Dr. Anthony Rosania, who is an emergency room physician at University Hospital and teaching faculty at New Jersey Medical School. And then I also have Monae Haskins, clinical informaticist at Holy Name Medical Center. And then finally, Mike Fortino, uh, healthcare consultant with Chenoa Systems. So, folks, welcome to our inaugural podcast, and I hope everyone's doing well.
Great. Happy to be here.
Yes, thank you. Happy to be here as well.
Thank you. Thrilled to be here.
Great. So, today we're going to talk about voice recognition in medicine and have a panel discussion around the topic. So before we engage in that, I'd like to just go overview of the key points in the history of the history of voice recognition and voice in medicine. And it started long ago, well before the advent of technology, where physicians and nurses engaging in complex clinical care would use scribes to help document their encounters. And then as technology matured, then many physicians and providers were using dictation and subsequent human transcription. With the advent of magnetic tape and then digital voice recording on dictaphones, then we had the advent of dictation and transcription. As transcription became more ubiquitous, it also became, strangely, more of a cost factor, and that paved the way for electronic health records to capture more information. So now we find ourselves in the EHR revolution, but still, EHRs have been linked to many things, positive and negative. And one of the negative things for providers is, burnout with excessive typing. Many generations of providers, physicians, nurses, mid-levels were not necessarily raised on a keyboard. They were raised on a pen. So now we're looking at innovative solutions from different parts of the industry on where there is now voice recognition, whether it's digital transcription into the EHR or actually artificial intelligence-based systems that are actually recording and translating and putting the transcripted note into the chart. So with that bit of overview in history, I'd like to invite my colleagues today to talk about their clinical experiences. So Anthony will speak from the physician's viewpoint, Monae will speak from the nursing viewpoint, and Mike will be talking about the consultant who has to ultimately implement these for all of the professionals that we mentioned above. So let's start our discussion today. So looking at voice transcription to the clinicians on the podcast today, have you used voice recognition systems, and what do you find about them that is helpful in either your direct patient care or in your support of clinicians who use this technology?
Well, I guess I can start. I think that, in my field, which is emergency medicine, what we really see now, I think everybody sees the benefit in documentation assistance, especially given the rate at which we see patients, the demands on our time in terms of volume, speaking with consultants. So I don't think that there's almost any debate really about a documentation assistance sort of methodology. I think the real debate comes down to scribes versus voice recognition software. And interestingly, despite sort of a lot of the added value that scribes and scribe companies will tell you that they offer, because they can prompt you for particular coding points, whether it be critical care or reading an EKG. and they can maybe even place calls to consults for you. I find it the majority of emergency physicians would rather actually have a voice recognition system than a scribe. I think that the feeling is they're able to sort of implement it more. It's sort of a more, from a usability perspective, it's more accessible. They can utilize it faster. They immediately see the results of their dictation. It's exactly what they wanted it to say, and there's sort of nothing lost in translation, so to speak. So I don't know that I see a big debate about using dictation as just used, or voice recognition, but that you still see to this day sort of this kind of push and pull between using scribes and the value added they offer and dictation software.
Great. That's a great perspective from from the emergency physician standpoint. Monae, tell us more about in the world of nursing and your role as a clinical informaticist and support. What are you seeing out with nursing and clinicians in your neck of the woods?
Well, thank you. So, in my organization, we struggle in the area of telephone transcription and voice recognition. And so, currently, the telephone transcription service, it takes about 5 days for the transcription to get into the patient's chart. So there, is definitely a patient safety issue for us because, if a physician or clinician needs to review those previous notes, let's say, for example, a post-op note that does not make it to the patient's chart until 5 days, that's a serious quality issue. So we are in this big initiative to push for voice recognition. However, we do see quite a bit of pushback from physicians that have been in practice, for a very long time. They feel as though the voice recognition software is not going to capture their voice or accent if they have one, in a timely manner. And then the fear is that they have to spend more time correcting the transcription or the recognition of their voice. So we have talks about that. And then from the nursing perspective, we are now starting to have those conversations as to enabling nursing to use the voice recognition software. We currently use Fluency Direct through M-Modal. And so from a nursing perspective, as being a nurse myself, we all know that documentation requirements are getting even more lengthier, and we spend a lot of time typing. So I'm definitely in favor and actually a part of the team that's been put together to try to push this agenda forward in terms of nursing being able to use Fluency Direct for some of the documentation.
Wow, that's a really interesting perspective. Very, very different than what we heard from Anthony. So now, Mike, as a consultant, as someone who looks at different solutions, different clients of different types, what have you seen from your vantage point in terms of this technology and some of the challenges for consultants in terms of introducing an implementation?
Well, thanks, Kennedy. Whenever we look at trying to assist and to help improve, workflow systems, we're always looking at pain points and trying to really understand what are the real pain points that you need to address in offering any kind of technology-based solution. And in this case, for voice assist and voice recognition technologies, some of the reasons that we've, come across for not implementing voice recognition technology have been budget, a preference for typing or the pen. Integration is up there as well, but one is concern around accuracy. Saw a recent article that it came down to looking at the risk of some of the voice recognition technologies that are out there, that have been out there in the past and today, They did a little bit of a study and said that there was a 7% error rate amongst across a varying number of voice recognition software. And those pain points, those concerns are some of the things that you really need to be able to address and to take a look at whatever solutions you may want to recommend. And getting to a recommendation, we always look at three main components to voice recognition. Ones that are, that we think will take an organization forward, right? Will help, really truly help the clinicians, whether they're in the emergency room or in a different type of a clinical setting. And those three components are: you look at the software that's available, and it should have a machine learning component, a natural language processing and natural language understanding component, and of course speech recognition. And when you look at those three components, if your solution has all three, then you want to look at the organization providing that solution. One, from a clinical experience perspective, have they done it before? How long is the data training process? Because in any AI-based solution, you're going to have to train data, and this is no exception. You want to look at error rates, and lastly, integration. How easily can you integrate this solution with your existing EMR or multiple EMRs that you may have in your organization? So those are just some of the points that we take into account when we're consulting with different provider organizations.
That's really fascinating because by the time we hear the perspectives from our clinician colleagues, they just know if it works, it doesn't. But a lot of us don't realize how much really goes into considering bandwidth, infrastructure, cost, integration. It's a fairly complicated move going to voice recognition. And for the clients that you've seen successfully implement, have they seen a benefit either in provider satisfaction, clinical quality? Are those things being measured right now out there?
So I would honestly say that it's just beginning to be measured, because what we're seeing, there are not a lot of mature solutions out there today that include those three components I mentioned: machine learning, NLP, natural language processing, and speech recognition. There are plenty of them out there that do a really good job at speech recognition, but the AI component, right, the artificial intelligence, whether it's machine learning or NLP, those are the two where there's still a lot of a lot of work needs to be done in making sure that those technologies really can deliver on the promises that they make. A couple of solutions that are out there today, they're actually listening in on the provider-patient conversation and actually recording that conversation, and through natural language understanding, NLU, they're able to infer intent on that conversation and come up with the notes. And one aspect or a result of that, they are providing those notes immediately back to the provider, so that they can verify that the what was stated and that they're capturing the notes correctly. So that's a real, what a huge benefit that could be. But how does that really impact the provider? Is that a great workflow or not? So all of those other things come into play as well.
Right, and that's great that you brought in the AI element, because there are several key workflow steps, right? When we talk to Anthony and Monae, they're in different stages of adoption of voice recognition technology, and right now, Anthony's talking about his emergency physician colleagues really picking up digital dictation, like your M-Modal or your Dragon, Medical One, things like that, to just simply dictate. but the next generation is already upon us where we're recording conversations. So at this point, I think there's now a differentiation we have to draw between strict dictation, which seems to be a fairly accurate technology, maturing technology. But then you talk about AI-based conversation capture is a different beast, it seems, altogether. And one
Mhm.
question I have for the group, um, is there, in your opinion, a different set of cognitive skills that a clinician needs to evolve again when they're talking about voice recognition, um, especially when it comes to transitioning from typing to a speech driven context? So Monet and Anthony, what are your thoughts about what you're seeing with your colleagues or even your own use of the system in this regard?
Well, at my organization, um, most of the feedback that I receive when we have these conversations about typing versus voice recognition, a lot of folks still prefer typing. They feel as though typing is faster, but then I do have a small percentage of providers that feel as though typing is tedious, especially if you have your surgeon, who's typing up the op report. I get most complaints from that. They definitely prefer to have a voice recognition software. Um, so that's kind of where we're at my organization. Anthony, how about where you at?
Yeah, I don't want to sort of lead people to think that I got an emergency department full of docs, using voice recognition software. It's more that those that do prefer it to scribes. And I think, and I'm interested in what sort of Mike's experience are. And I think that's in terms of the AI aspect, I think that's where the hurdle lies, because one of the reasons you start to see a transition from scribes over to voice, dictation or voice recognition in that context is, clinicians are pretty quick to grow frustrated if there's a lot of corrective work that needs to be done,
Yes,
right?
yes, exactly. That's what I find
That's
often.
why you're not seeing why the AI is not quite there. Because if I can tell you, if you it could be good like 75% of the time, but if the other 25% of the time, there's a lot of work that needs to be done editing that note because the conversation with the patient was not really interpreted well, then that's you're just gonna from a change management perspective, you're just not gonna get adoption. It's sort of like people just drift back to the regular. So I don't know. Have you seen like really good adoption of any of that kind of technology, Micah?
Not yet. And I think the biggest hurdle is I mentioned it, I guess, briefly before, is the time it takes for your data models to be built, right? For the AI components to learn, because not everyone speaks the same way. Everyone has different, a little bit of an accent here. I've got a Jersey accent from time to time and things like that. But it really comes down to building the data model, and how do you do that in such a way that um, you're not hurting yourself when it comes to a more pervasive adoption of the technology once you go live. So that's still a challenge. And honestly, I haven't really seen anyone or had personal experience in overcoming that at this point.
And one of the other things, Mike, you talked about integration. So that's one of the major
Hmm.
pain points within my organization, because we utilize Improvada single sign-on, and it does not play well with
Hmm.
Immodal. And so a lot of times we have frustrated providers that call up, because it's not syncing.
Right,
And then
right,
there's
right.
all these other steps that we
Hmm.
right now have imposed on the provider to go
Hmm.
in and change the settings. And so we've had quite a bit of pushback from that, because now they don't even really want to use it
Right.
Because is it going to interfere with their single sign-on, or is it going to, sometimes they're at a tap and go workstation, it's not going to pick up Fluency Direct. So
Right.
definitely some more work needs to be done there.
Yeah, and the and you should always look for those. So, voice recognition, AI, ML, NLP, all these emerging technologies, they're continuing to improve and evolve. But, there's others that will complement those technologies, like robotic process automation, right? Where you could actually, you don't necessarily have to worry about single sign-on. If they've got their voice recognition app, they're using it on their iPhone, the workflow's figured out. And then when it comes to integration, you could use robotic process automation to then insert those notes into the EHR, right?
Right,
And
exactly.
and so that's like a fourth component to a solution that you want to look at. Hey, they've got the top three, ML, NLP, and that fourth thing is, well, do you use RPA, in order to do that data integration, right?
So, one final question for our panel, and very provocative because we're looking at two fundamental voice recognition technologies that seemingly pervade the industry, where organizations and providers are in various forms of adoption. You have dictation, straight up dictation, which, you know, is seemingly the current standard, if you can call it that, versus conversation capture, where you're talking about these AI methodologies and NLP, NLU methodologies. Now, when we step back and look at this, look at what we've discussed, which technology is better and for whom? So, Anthony, tell us from the physician standpoint, what are your thoughts as an informaticist? What do you think is seemingly more appropriate for the ER physicians and the shop where you work?
I think we sort of hinted at some of the concerns, but assuming those concerns are put aside, I think that a robust conversation capture is always going to be is going to win out because it's a time saver. It really is a game changer, right? Whereas you heard Monae speak to the fact that she has people who think they type faster, and they probably do. I mean, like, you can type some words faster than you can speak them for sure, and you don't have to go back and retype things. But I think if you had really reliable conversation capture, you walk out of the room with the work done, right? So now you're doing things in parallel. Now you're really improving productivity, and you're taking the physician away from the computer terminal, which is sort of, I think, what we all know we've sort of been frustrated with for the past 10 plus years, is that we seem to be spending more and more time at computer terminals. So I think hands down conversation capture, assuming that we get to the point where and I think at some point we'll be there.
Great. Monae, your thoughts on it?
I kind of agree. I agree with Anthony, hands down, conversation capture, especially from a nursing perspective, right? So, oftentimes if you're working in a clinic or an outpatient facility, you get the patient call. If you have that conversation capture, robust AI, that patient call can be, quickly translated and actually, show up in real time. And I think that we would see actually a drop in triage time, if you will, because it is faster. So I definitely think that conversation capture is the way to go.
And then finally, Mike, what are you seeing with your clients and where you're seeing these technologies being adopted, especially by early adopter providers and organizations? Do you see these perspectives in parallel for what you're seeing out in the field?
For the most part, yes. And I think there's a real opportunity with some of the providers who were early adopters that have at least they're doing the dictation and they've already done a lot of data capture. That is a treasure trove of data that you can utilize for, your machine learning and NLP model development. So, they kind of have the basis for which you to really put together or to support a good conversational capture capability, right? So I think that therein lies a great opportunity, right? There's a lot of good data out there today, right? There's a lot of hard work that's been done. Now you can start doing some proof of concepts around some different technologies and make some smarter decisions around which way to go.
Mike, is that data readily available? Like,
It generally is not, but sometimes it is. It's probably easy. It may be easier to get at that data than it would be for you to create it, right?
oh, yeah.
Right. So, I would like to take an opportunity to thank our listeners for tuning into this podcast. I would like to thank Anthony, Monae, and Mike for offering three unique perspectives on, the state of voice recognition in clinical medicine. And right now, I think we're all waiting with bated breath to see conversational capture quickly evolve as pressure comes on to consultants, nurses, physicians to do more work in less time, as well as improve our clinical quality and patient satisfaction. It seems like dictation is going to be a readily available foundation, but looks like conversation capture can take voice recognition to the next level. So, with that, this concludes our inaugural episode of the New Jersey HIMSS podcast. And I would like to thank everybody for joining us today, our panelists, as well as our listeners. And we will be back with more. Have a
Thank you.
Thank you.
Thank you.